Hello, in this video I will review Tachycardia Algorithm. When the heart rate is above 150 with the pulse, patient needs to be assessed for apparent causes of tachycardia that could be H's and T's: hypovolemia, hypoxia, hyper and hypokalemia, high or low hydrogen ions, which is acidosis, alkalosis, hypothermia, tension pneumothorax, thrombosis pulmonary, which is PE, cardiac tamponade, thrombosis coronary, which is myocardial infarction, drug reactions. Magnesium levels should be checked, or it could be something simple such as fever, pain, fear. Necessary to ensure that the patient airway is patent and maintained, and if needed, assistance with breathing can be provided. Patient is connected to supplemental oxygen, cardiac monitor is monitoring the rhythm, and blood pressure and oxygen is monitored. Patient has adequate IV access for possible medication administration such as adenosine, beta blockers, calcium channel blockers, amiodarone, and sotalol, and so on. 12-lead EKG can also be requested. Next step is to determine if the patient is stable or unstable, whether patient's tachycardia causes the patient to be stable or unstable. Patient considered unstable by presence of severe hypotension, signs of shock, acute heart failure, ischemic chest discomfort, or acute altered mental status. If the patient is stable, then the treatment most likely would be pharmacological. If the patient is unstable, treatment would be with electricity in the form of synchronized cardioversion. If patient is stable, then the next step is to determine if the patient's QRS complex is narrow or wide. This will give information if the problem is atrial or ventricular. If the QRS narrow, it is atrial problem, and if QRS is wide, it is most likely ventricular problem. Depending on the problem, if it's atrial or ventricular, different sets of drugs will be used. If it is atrial tachycardia, treatment would be with vagal maneuvers, beta blockers, calcium channel blockers, and if ventricular tachycardia, treatment will be with amiodarone, procainamide, or sotalol. There's exception if the patient has pre-existing bundled branch block. EKG may show a wide QRS complex, while the impulse itself is coming from the hyperexcited atria. So if the QRS is narrow, then the cause of tachycardia is in the atrium of the heart. That could be re-entering signal from the atrium, could be ectopic beat that fires at a very fast rate, could be multiple ectopic beats, or an ectopic beat in the atrioventricular node, causing junctional tachycardia. Treatment of narrow QRS tachycardia is with vagal maneuvers, such as blowing very hard on a syringe trying to move the plunger, or blowing through a thin straw. Bearing down like having a bowel movement, or application of cold pack to the face. Adenosine can be given if rhythm is regular. Some providers may use adenosine to identify the cause of supraventricular tachycardia. Adenosine blocks the AV node and has very short half-life. Adenosine can be given to block the AV node, thus blocking the re-entering impulse. Also, if QRS is narrow, beta blockers can be given, for example, propranolol or metoprolol. Also, calcium channel blockers can be given, for example, diltiazem. If patient is hypotensive, consider adding bolus of fluids or raising the legs when treating with beta blockers or calcium channel blockers. If the cause of tachycardia is an electrical impulse that is not going through the AV node, adenosine will be ineffective. Adenosine will be ineffective on re-entering tachycardia that is outside the AV node and Wolff-Parkinson's-White syndrome, where a patient has accessory pathway. When adenosine given to a patient with Wolff-Parkinson's-White syndrome, their heart rate will accelerate to 300 beats per minute. It is best not to attempt to block AV node for a patient with Wolff-Parkinson's-White syndrome with beta blockers or calcium channel blockers. AV node has a natural tendency to slow down electrical conduction. Other pharmacological therapies need to be selected. Consideration may be for amiodarone, procainamide, sotalol. Another clue that the patient has Wolff-Parkinson's-White tachycardia could be delta wave, which is this early rise onto the R wave in a different leads on 12-lead EKG. If patient had tachycardia caused by atrial fibrillation or atrial flutter for extended period of time, patient may have developed a clot that is bouncing in the atria. Anticoagulation should be initiated before treating atrial fibrillation or atrial flutter to avoid possibility of thrombolytic stroke. If unsure how to proceed with the treatment, consider expert consultation. Now, if the QRS is wide and patient is stable, if the QRS is wide, the cause is most likely ventricular unless patient has SVT with pre-existing bundled branch block. Adenosine can be given if the rhythm is regular and monomorphic. Adenosine is contraindicated for irregular or polymorphic tachycardia. Treatment for wide QRS tachycardia could be amiodarone 150 mg over 10 minutes loading dose, followed by infusion 1 mg per minute for the first 6 hours. Procainamide can be given 20 to 50 mg a minute until hypotension ensues or QRS duration increases by 50%, or maximum dose of 17 mg per kilogram is given, or until the tachycardia resolves. Maintenance infusion of procainamide is 1 to 4 mg a minute. Avoid procainamide with prolonged QT interval or CHF. Sotalol can be given 100 mg or 1.5 mg per kilogram over 5 minutes. Sotalol should be avoided with prolonged QT interval. If unsure on the treatment, consider expert consultation. Now, when determining if the patient is stable or unstable, if the patient is determined to be unstable due to the presence of hypotension, signs of shock, acute heart failure, ischemic chest discomfort, or acute altered mental status, tachycardia is treated with synchronized cardioversion, which is a delivery of electrical shock on the R wave. Shock with different volumes of joules can be delivered to achieve conversion to stable rhythm. Cardioversion is painful. Some refer to cardioversion as being hit in the chest with a baseball bat. Consideration for providing sedation should be made before cardioversion. Unstable tachycardia most likely will be treated with electricity. However, some providers may consider adenosine if the QRS complex is regular and narrow. First dose of the adenosine is 6 mg. Second dose 12 mg. Medication must be flushed with 20 cc syringe. Three-way stopcock can be used for rapid administration. To facilitate administration, extremity with IV access can be elevated. If the tachycardic rhythm is refractory to medication and electricity, search for underlying cause needs to be continued. Energy level may need to be increased, additional medications may be necessary, and expert consultation is required. So you just made it to the end of the video. If you found the video useful, please click that like button. I hope you enjoyed it. Thank you for watching, and I wish you great success.